welcome back or to my channel. My name is Sophie if you are new here, and today's video for Vlogmas is going to be a medical assisting related video, and it's going to be something along the lines of what I do on a daily basis as a medical assistant in an OB/GYN clinic. So I have been a certified medical assistant for over a year now, and I have always worked in an OB/GYN clinic. That's where I had my clinicals when I was in MA school. So this is all I know, and maybe one day I will branch out and go to a different clinic and try a new specialty. But first, I just want to also put out there that this, as a disclaimer, this is my experience at my clinic, and I'm sure if you're a medical assistant and you're watching this and you work in OB, it could be totally different. And if you are an MA student right now and you are thinking about going into OB, it could be totally different when you are working. So again, this is just my experience, and I don't want anyone to think that this is the only way it will be, because obviously that's not the case. Everywhere is going to be different, but again, just my experience. So first, I'm literally just gonna go like day from the beginning to the end, and then things in the middle of the day I'm gonna talk about. And I don't know if this video is gonna make sense or if it's even gonna like be informative. I'm gonna try to make it informative. If you guys have any questions though, just please ask. I want you guys to like feel confident, and like I want you guys to like learn something from this video. If that's why you're watching it, I don't want you to leave this video like, what? I'm confused. So just like ask me, because then I can try to explain it better. So first, I have arrive 15 minutes prior to patients. I always say 15 minutes, but obviously the earlier, sometimes the better, if you have things to be doing when you get there. So when at my clinic, we usually start patients around 8:30. Sometimes it's 8:45 and sometimes it's 9. It really just depends on the provider you're working for and whether they're on call or if they like to start earlier or later and things like that. So at least 15 minutes prior to your patients, you're going to want to turn everything on, lights, computers, unlock medicine cabinets, unlock the stock, or if your supply room has a lock on it, unlock that, and like stock rooms if you need to. I always print a schedule for myself of our patients, and then I print a schedule for the provider I'm working for. Some providers want the schedule, some probably don't look at it, but I print it off for them anyways, just in case they want it. Again, I work for one main provider, but obviously if they're on vacation and you're filling in, you just learn to get comfortable with everyone, but you're never going to be fully comfortable with the provider until you have been with him or her for a long time and you just like start to understand them. So don't be discouraged if you're like, I don't know what my provider wants. Like, you'll learn eventually. And then you'll start rooming patients as they show up. So at our clinic, we have a 15-minute arrival time, so we want them to arrive 15 minutes before we actually want to get them in the room. And that is because a lot of our patients have paperwork to fill out, and then a lot of our patients are also late. So if we tell them an arrival time, hopefully they'll be there by their actual appointment time. And then some people are 15 minutes early to their arrival time, and then they get upset because they've been waiting for 30 minutes when that's really like their own fault. So we like to start our morning. Some providers have a schedule where they like, at 9 o'clock we're gonna see this type of patient, at 9:30 we only want to see this type of patient. And some providers just are like, if there was an open, throw anyone in there. So there's new OB patients we see, so that's around 9 to 12 weeks. It's their first appointment with the doctor, and then at that appointment you do a bedside ultrasound. So we have this little ultrasound machine we wheel in there, so we need to know if we need the ultrasound. Then at their first appointment, if they're due for a PAP, we will set up for that. If they're due for an exam, like any type of exam, we'll set up for that. So we'll set out the gown, any swabs for any testing we need to do, and then we hand out bio cards for all the pediatricians so patients can start to look into that. We just answer any questions for them that we can, or we'll, you know, let the doctor know that they have any specific questions. We also will do paperwork for insurance if needed. Usually the front desk can take care of that, but if it's like more of a medical standpoint, like we fill out paperwork for the genetic testing. If the patient decides they want to do that, we put the orders in the computer, and things like that. If it's flu season and they want a flu shot, we'll give them that at that time. So those are new OBs, that's what we call them. I don't know if other clinics call them that or what. And then we have repeat OBs. So this is at 16 weeks, 20, 24, 28, 30, 32, 34, and then 35, 36, 37, 38, 39, and 40. Give or take, you know, sometimes patients have to miss one and sometimes they want to be seen more and whatever. So for those repeats, at 24 weeks, we give them their glucose drink. So we want them to do that by 28 weeks. So that's that sugar drink that they check for gestational diabetes. At 28 weeks, we'll give them their Tdap, which is their tetanus, diphtheria, and pertussis injection. And then we'll give them their RhoGAM injection if they are Rh negative. So you just start to learn, like at 20 weeks, we want to make sure they had their anatomy ultrasound, and we can print off that ultrasound report for the doctor to look at. And at 24 weeks, you want to make sure that they've been given their glucose drink. So you just start to memorize things and write yourself cheat sheets. And it's actually not hard, anything we do. It's just like you gotta remember it. You don't learn any of this stuff in school, like especially for your specialty. You're not learning at what time you give this and blah blah blah. So it's just like an on the job. You just start to remember and learn. And then so at those repeats, we'll make sure that there's a Doppler set out so the doctor can listen to the baby's heartbeat. We don't do that. The nurses and MAs don't do that. There are some nurses that are trained into doing it. So if the doctor needs to go to a stat C-section or something and the patient is okay with the nurse doing it, they'll do it quick. And there's a measuring tape. They measure, you know, the belly. And then we also grab weight, blood pressure, and then we check their urine every appointment in a little Dixie cup, and we check for sugar and protein. If there's sugar in your urine, that could be a sign of gestational diabetes, and if there's protein in your urine, it could be a sign of preeclampsia or high blood pressure. So we monitor all of that, and then some patients around 28 to 32 weeks, patients will need a non-stress test if indicated. So if they're AMA, which is advanced maternal age, GDM, which is gestational diabetes, IUGR, which is intrauterine growth restriction. So if their baby's really small, like under the something percentile, I don't know exactly, or like preeclampsia, hypertension, whatever, we'll do continuous monitoring. So sometimes they'll get more ultrasounds, or they'll just need more so sometimes they'll need ultrasounds or just these non-stress tests. Some patients are once a week and some are twice a week. It's just all like, you don't need to know. You like, literally, if you're watching this and you're like, how am I ever gonna remember that? You will remember it eventually, but just know, like, you don't need to know it. It's all in their chart. The doctor writes notes and you can like go in and see what they want. So a doctor's never gonna expect you to know something that like you're like, we're not the doctors. Like, that's what they're there for, if that makes sense. So those are repeat those are repeat OBs, and then we see a lot of postpartums. So 6 weeks after they have their baby, they come in. We do well, we don't. The doctor will do an exam. We will order any birth control if they want it. If they want an IUD, we'll set up for that and we'll get that going. If they want the Nexplanon, we'll set up for that. If they want to do the depot shot, we will schedule them every 3 months for a year, and then they can come and get that depot shot. So those are like all of our OB patients, and then we see a lot of GYN, obviously, gynecology. So we see mostly annual exams, A lot of women will go to their primary care provider for an annual, but a lot of them will also come to the gynecologist for their OB, or a lot of them will come to their gynecologist for an annual exam. So if they're under 21, it's mostly just a talk. You can refill any prescriptions. If they have any concerns, go over like anxiety and depression. The doctors can, you know, fill prescriptions for things like that. And then we collect urines for like STD checks and things like that. And then if you're over 21 and you're due for a PAP, we'll set up for that. Some doctors do it every 1 year. Some doctors do it every 3. Depends if they have history of abnormal or family history or things like that. So a lot of annuals, they're time consuming because you kind of go through all of their history. Especially if they're a new patient that needs an annual, you have to get records from different clinics, and I usually just ask reception. I'm like, hey, can you get records for so-and-so? And then they're really awesome about it, but if you want to do it yourself, you definitely can. I just usually don't like to do it myself. And of course, we see a lot of older women that are wanting hysterectomies. So if they have a lot of abnormal bleeding, things like that, we'll set up for an endometrial biopsy, which is a small biopsy of the uterine lining, and we send that to pathology. And then the pathologist will review it and kind of give the doctor a better understanding of what's going on, and then we can schedule them for surgery if needed. And the nurses at my clinic take on surgery things. They do pre-op, like scheduling, instructions. That's not the MA's role so much. That's just like our clinic and how we do it. So I can't give a lot of information on pre-op and post-op just because I don't do a whole lot of it, but we do see quite a bit of those patients. And then we also see quite a bit of like problem visits. So if they're having abnormal menstrual cycle, concerns for like STDs, like things like that, we see a lot of girls from like 12 to women that are 90 coming in. And problem visits are, this is gonna sound weird, are probably my favorite type of visits, just because I feel really like important. Like, you're typing the note for the doctor to read, and the doctors read it, so the more information you can give them, the better. So if you're like, so-and-so is a blank age female here today for this concern, let's say like a yeast infection patient has tried over-the-counter medicine for 7 days, no relief. You just get all this information out of the patient and type it in, and a lot of times you can predict what the doctor will want to do. So they're going to want to do a swab, or if they'll want to do a urine, you can order it and pend it, so then the doctor can just sign it and send it. So the more you work with your provider, the more you'll know what they will do in certain situations. And all the providers I work with have what we call a preference list that their staff makes. So if you're switched from provider to provider, you just look at their preference list and you're like, this is how they want this done, and this is how they want this set up, and it's so helpful. So that's like throughout the day. You're just rooming all sorts of different patients. And then after you're done rooming, also usually there's a lunch in between there around 12 o'clock. Hopefully you'll get a lunch. And then after rooming, you restock rooms with instruments like speculums, tenaculums, scissors, gel, just like everything. And then there's like daily chores we have at our clinic that mostly the MAs are in charge of, because this is when the nurses look in what's called in basket, and then they reply to patient questions, refill prescriptions. And MAs can do that, but the nurses do it more, and then the MAs will do more like of the scut work, like stocking rooms and cleaning, and stocking the bathrooms with supplies, and unpacking the supply room, taking the shreds, taking all of the confidential papers to the shredder. Then once all of that is done, if you still have time, you can call patients with normal results, send out normal test result letters, just like tie up all loose ends at the end of the day. So there is, I mean, the days are busy, they go fast, and I'm sure I'm missing a ton of stuff that we do, but I couldn't think of anything else off the top of my head. So if you work in an MA, or if you are an MA and you work in an OBGYN clinic, I would love to hear your feedback from this video. If you have any other specific questions, I would love to answer them for you. And if you're in MA school or you're an MA, share this with a friend that you think would find it helpful or interesting. That would help me out a ton as I'm trying to get to 5,000 subscribers. And don't forget to give this video a like. That helps me out so much with the algorithm. Leave a comment if you'd like, and I hope you guys enjoyed. I'll see you guys in my next one. Bye guys.
Oh, jingle bells, jingle all the way. Oh, what fun it is to ride in a one-horse open sleigh. Jingle bells, jingle all the way.